Okay. I'm Dr. Bunn, and nice to meet you. So we're going to go over statistics, pathology, staging, types of lung cancer, treatment of early stage, treatment of local regional stage, and treatment of advanced stage. So the red line is the mortality rate from lung cancer in males on the top, and the red line for females on the bottom. And you can see the good news and the bad news on this slide. The good news is the red lines are declining over time. So mortality rate in both males and female from lung cancer in the US is declining. The bad news is it's still number one. It's still the leading cause of cancer death in both males and in females. But as you see on the right, the survival rate for people who are diagnosed with lung cancer is improving for every stage. And that's because the treatments that we're going to talk about in a second are getting much better, as they did in melanoma. So not all lung cancers are the same, and we describe them first by the pathologist who looks at the cells under the microscope. And basically there's adenocarcinoma, which is by far the most common histology. Second most common histology is squamous cell carcinoma. Small cell carcinoma is the third most common, and it's declining as cigarette smoking is declining, because almost all small cells occur in smokers or former smokers. And large cell undifferentiated carcinoma is the least common. So when a patient has a biopsy and has a tissue diagnosis, they need to be staged. And we do brain MRIs, CT PET scans to stage them. We stage them by the size of the primary tumor, which lymph nodes are involved, and whether there's metastatic disease and what sites of metastatic disease. And you can see the staging classification really separates people with different prognoses. With not such a bad prognosis in stage 1A, where surgery alone is the treatment, and then declining survival as the stage increases. Now, in the old days, that's about what we did. We had histology and stage. Now, we have to characterize the tumor from both a molecular point of view and from an immunologic point of view. And we can't treat the patient until we know the molecular features, as well as the histology, and the immunologic features. So this shows the most common mutations and genetic alterations that occur in lung cancer. KRAS mutations being the most common, EGFR mutations being second most common, then HER2, BRAF, MET, NRAS, MEK, as shown on the slide. And our practice, and I believe the standard now, is all patients that have non-small cell lung cancer, all of the patients of any stage, need to have this done before they start on treatment, because the treatments are different. And does it matter? This is a very old slide where people that had genetic alterations got a pill, a tyrosine kinase inhibitor, for that at any point during their treatment, or did not receive a tyrosine kinase inhibitor. And you can see these oral agents make people live much longer. They also have far fewer side effects than any other treatment, and so they're the preferred first-line treatment. So how do we know? In the old days, we had FISH, PCR, and IHC. And the problem was each of those is specific for each genetic alteration. And so if you wanted to test for 8 different genetic alterations, it required 8 tests. And oftentimes that took too much tissue. Nowadays, with whole exome and whole genome sequencing on NGS panels, we can test for all of the 8 molecular alterations at the same time. And so the preferred test is an NGS-based assay that covers all of the molecular alterations that occur. Now, how often do we do that if that's the standard? So on the left here is looking at how often people test for various genetic alterations. And on the right, where NGS is done, and you test for all the genetic alterations, unfortunately, that's only happening in about 50% of people in the US. And so we need to have educational meetings like this one, where you go back, and if the doctor didn't order an NGS test, you say, Dr. Bunn said you're supposed to order an NGS test. Hopefully that number will increase in the upcoming years. Now, originally those NGS tests were done on the tissue, and the tissue is still the most sensitive way, but we can look for circulating tumor DNA in the peripheral blood. And so these circulating tumor DNA tests are very specific. If they're positive, that's a real result. If they're negative, it's not as sensitive as a tissue-based test. So if the result comes back faster in the blood test, then you can act on it, because if there's a positive finding, it's for real. If it's negative, though, you have to wait for the tissue, because occasionally the tissue will be positive when the blood is not. So NGS on everybody, and then immune testing on everybody, and the one that's approved at the moment, although there's a number being evaluated, is to look at the expression of PD-L1 on the tumor cell. And you just had a lecture explaining how PD-1 binding to PD-L1 inhibits the T cell from killing. So tumor cells want to evade being killed by lymphocytes, so they make PD-L1. And the higher the PD-L1, the more likely it is that immunotherapy will work. So everyone needs to have a PD-L1 test and an NGS test. So PD-L1 is quantitated by the fraction of cells that express the PD-L1 protein. Negative is on the left, that's 0, 1 to 49, intermediate, in between, and greater than 50% of the cells being high. And the higher it is, the more likely immunotherapy is to work. So even if it's 90%, it's more likely to work than if it's 50%. Okay, so before we get into treatment, why is lung cancer incidence going down? It's because smoking causes lung cancer. And if you get lung cancer and you get cured, you have a chance of getting a second lung cancer. And that second lung cancer risk is about 1% per year. The sooner you stop smoking, the risk goes down. But smoking, fortunately, has gone down from 50% in males to about 18%, and 25% in females down to about 18%. But 18% is still too high. So what about early stage disease? So people who get stage 2 and 3 are generally treated with surgery. But those that are not cured by surgery almost always fail in distant sites. Metastatic disease occurs. So very early on, people said, well, what if we give chemotherapy, even to resected patients? And we could give the chemotherapy before surgery or after surgery. On the left shows after surgery, and on the right shows before surgery. And you can see that the systemic therapy improves the cure rate, not by a whole lot, but by about 5%. So giving chemotherapy either before surgery or after surgery improves the outcome. Giving a bevacizumab or an EGFR TKI had no effect. But then we came to immunotherapy, and immunotherapy added on to the chemotherapy. So in the preoperative setting, giving chemotherapy plus immunotherapy first there are these 5 randomized trials, essentially all of which have been completed, but only one presented thus far. And the one presented thus far is Checkmate 816. This was a study of a platinum doublet with or without nivolumab, which you just heard about from Dr. Lewis. And if you look at complete response rate, that is no viable tumor at the time of surgery, you can see that it's much higher with the combination than with chemotherapy alone. And major pathologic response, that is a good response but not complete, also much higher. Now, just recently in the New England Journal, the disease-free survival, event-free survival from this study were published, and as well as the overall survival. And you can see chemo plus nivo, the combined is on the top in the yellowish curve, and chemo alone in the gray curve. So this was recently approved by the FDA. So one standard approach is to give nivo and chemotherapy before surgery and then surgery. Now, the trial didn't randomize people to get nivo or not after the surgery. And what we need to do is find out which patients are going to be cured. So many of those patients with a complete pathologic response are cured and don't need a year of adjuvant immunotherapy. But we don't know how to define them at the moment. Hopefully, circulating tumor DNA will be sensitive enough to know whether we need to continue the immunotherapy after the surgery. But immunotherapy doesn't work so well in people that have these molecular alterations. And so what should we do before surgery for people with molecular alterations? Should they receive the appropriate tyrosine kinase pill before surgery, or what? And once again, randomized trials are ongoing, but there are no results. What about giving chemo-immuno after surgery in the adjuvant setting? And these are the randomized trials here. Once again, all of these have completed enrollment, but once again, only one has been reported thus far, IMpower 010. And that showed an advantage of chemo-immuno as well. So whether you should give chemo-immuno before surgery or after surgery is somewhat up to the institutional preference. At our institution, we believe it takes time to schedule patients. We believe that preventing systemic disease at the earliest time point and making it easier for the surgeon when the tumor shrinks is a better approach. So we're generally using the neoadjuvant approach. And then, once again, molecular therapies, immunotherapy doesn't work so well if you have a molecular driver. So after surgery, should you get a tyrosine kinase inhibitor? And this is a study called ADURA, in which patients were randomized to get osimertinib for 3 years after surgery. These are all patients with an EGFR activating mutation. So they got 3 years of a pill or just chemotherapy or nothing after surgery. And you can see the event-free survival is much better than those that got the osimertinib. So this is also approved in the adjuvant setting for people that have an EGFR mutation. So after stage 1, 2, and 3, we get to stage 3B, which means people have disease confined to their chest, but positive lymph nodes in the mediastinum. And the standard treatment for many, many years for them was to get chemotherapy plus radiation therapy. And then, as Dr. Lewis mentioned, immunotherapy came along. And so when they completed the chemotherapy and the radiation, they were randomized to get a PD-L1 inhibitor, durvalumab, or a placebo. And this is the latest update of that trial, showing at 5 years, 43% of the people that got durvalumab as adjuvant therapy were alive, compared to 36% of people who did not. So in stage 3 disease, chemoradiation followed by immunotherapy is the standard. And it's pretty impressive that the cure rate is over 40%. So this is the principle of the 40% of people that we test with NGS and have a positive result. And what happens is when you have a genetic alteration, inside the cell, the conformation of the receptor is changed so that ATP can bind. And that ATP binding to the receptor activates the MAP kinase pathway that Dr. Lewis showed you. Now, for each of these molecular alterations, drug companies have made tyrosine kinase inhibitors that bind into the ATP binding pocket better than ATP. So ATP can't bind and there's no signaling. So this is true for all the 8 alterations that we're going to talk about. There's a tyrosine kinase inhibitor that outbinds ATP for the ATP binding pocket and blocks signaling. So in lung cancer, there's 8 molecular alterations shown here for which there are approved tyrosine kinase inhibitors. And to make it complicated for the nurses and the physicians, for almost all of these, more than one drug is approved. And they all have horrible names. But we need to understand which tyrosine kinase inhibitors are approved for which of the genetic alterations. And we'll go through a couple of these. I'm not expecting you to pass a test on all 8 when we get done. But this basically shows what happens now. So this is a randomized trial of what we call a 3rd-generation EGFR tyrosine kinase, osimertinib, versus something else. And you can see that whether you're from Asia or from North America, you have a much better survival if you get osimertinib. And you can also see that at 3 years, 3/4 of the patients or more are alive. Remember in the old days when we were doing chemotherapy, the median survival was 12 months. So this is a pill, and you can see that the median survival is not reached at 3 years. So that was for the majority of EGFR mutations called deletion 19 and L858R. There's another EGFR mutation called exon 20, which is an insertion mutation. And this is different than the others, but this has 2 drugs approved. One is a monoclonal antibody called amivantamab, which is a bispecific antibody, and the other is a tyrosine kinase inhibitor called mobocertinib. BRAF mutations in lung cancer, Dr. Lewis showed you everything you need to know already, and that is that the most common one, V600E, responds to BRAF inhibitors like dabrafenib, but if you give a MEK inhibitor as well, you get a better outcome. So the standard in lung cancer and the standard in melanoma for these is the same, trametinib plus dabrafenib. And there's the survival from that. Now, the most common mutation is in KRAS. And KRAS has been more difficult to break for a variety of reasons, one of which is there's a bunch of different mutations that behave differently. As you can see in blue, the most common one is a mutation called KRAS G12C. But there are other KRAS mutations as well. And the drugs are different for the different KRAS mutations. So the most common, as you saw, was KRAS G12C. And there are two inhibitors, tyrosine kinase pills for this. These are very similar and have very similar response rates. So far, sotorasib is the one that's approved by the FDA. Now, Dr. Lewis was telling you before that when you have a tyrosine kinase inhibitor or an immune therapy for BRAF mutant melanoma, it's probably better to give the immunotherapy first. Now, we believe in lung cancer that it's the same. That for KRAS mutations, immunotherapy would be given first, but then sotorasib would be given after that. MET mutations occur in people, and there are two approved drugs, capmatinib and tepotinib, shown in the middle here, that are both approved as oral agents for patients with MET splice mutations in exon 14. Crizotinib is also approved, but capmatinib and tepotinib are better. Salvolitinib is under investigation for resistance mutations. HER2 mutations, there's an antibody drug conjugate. The antibody, just like in breast cancer for HER2, is trastuzumab. And trastuzumab is conjugated to a toxin, a drug, in this case, deruxtecan. And this antibody drug conjugate of trastuzumab and a drug deruxtecan, if it's shown on the bottom, had a response rate of 61%, which is higher for HER2 mutations than any other treatment, and a better progression-free survival as well. ALK-positive non-small cell lung cancer is probably the second or third most frequent alteration for which there are multiple approved tyrosine kinase inhibitors. The first was crizotinib, shown in blue, and the second was alectinib, shown in the red. One of the major advantages of alectinib over crizotinib is it crosses the blood-brain barrier and prevents brain metastasis. And you can see the 5-year survival rate for these patients is over 50%. Remember, not so long ago, 12 months was the median survival. ROS1, similar results. You can see here 3- and 4-year results over 50%. RET, also 2 drugs approved, and several coming up for resistance mutations. TRAC fusions, entrectinib approved there as well. Larotrectinib also approved for TRAC. So patients that get these tyrosine kinase inhibitors, you saw that their median survival is somewhere between 3 and 5 years. But they're not cured. Some of the patients treated with immune therapy are cured. But these tyrosine kinase inhibitors don't kill all the cells, even though all the cells have the alteration. There's always persistent cells that at some point get resistant. Now, they may get resistance by a new mutation in the same gene, a resistance mutation in the same gene. They may get alteration in a different gene. So if you have EGFR in the beginning, you may get ALK or ROS1 later on. Or sometimes we don't know the mechanism. But we have to test to see what the mechanism is. So everybody that gets a TKI when they progress needs to have another NGS test to see whether there's a new alteration for which there's a pill or not. Okay, PD-1, PD-L1, Dr. Lewis told you about. So one of the first trials took place in people that had some expression of PD-1, greater than 1. And people were randomized to platinum doublet chemotherapy or single-agent immunotherapy. And single-agent immunotherapy won. That's the blue line on the top. So the patients that had TPS 0 and low PD-L1 didn't do so well. So those patients were randomized to receive chemotherapy alone or chemotherapy plus pembrolizumab. And you can see here that the patients, irrespective of their TPS score, did better if they got chemo plus immuno. So what happened with all this? Chemo plus immuno became the standard for people with a TPS of 0 or 1 to 49. People with a TPS over 50 could get immunotherapy alone or both. In our practice, unless the patient is very ill, single-agent immunotherapy is given. Squamous patients, the same thing, they get a different chemotherapy, but people were randomized to chemo or chemoimmuno, and irrespective of TPS, people that got chemoimmuno did better than people who got chemo alone. I think in the interest of time, I'm going to skip those because there are other agents. So they're all, in my estimation, about the same. We have 2 PD-1 inhibitors that are approved, pembrolizumab and nivolumab. We have 2 PD-L1 inhibitors that are, well, actually there's 3. Cemiplimab is approved as well for TPS over 50. We have durvalumab and atezolizumab that are approved for PD-L1 inhibitors. In my opinion, the side effects are very similar. The efficacy is very similar. So what do we use? We use what was done in clinical trials and approved by the FDA. So as you saw for high TPS, pembrolizumab was first, and that's used most of the time. There's also trials showing Nivo-Ipi, atezolizumab are okay, but pembrolizumab predominates. 1 to 49 PD-L1, they almost all get chemoimmuno. The trials with pembro platinum doublet were done first. That's the most common thing, but it's okay to use one of the other ones. TPS 0, once again, pembro chemo was approved first, and that has the most common use. So I think I have 7 seconds left. I stayed on time. If there's any questions, I'd be happy to answer them.